Hi guys, welcome to week 2. So we are going to continue on in chapter 1 for this week 2 lesson. So I'm going to start off talking a little bit about tumor board. So the first half of the chapter we kind of went over what it is as an overview, a little history on it. We also covered detection and we covered staging. Now we're going to go into treatment options. So at this point, our patient has, been screened, maybe something came back positive. They went in for some diagnostic scans or diagnostic labs or not diagnostic labs, but more like a workup. They did their workup through those diagnostic testing. They did, find disease. So now we're moving on to the treatment options. The first point that your book talks about is tumor boards. So tumor boards are, it's a way for all the doctors of the different types of treatment options to meet together and discuss cases. And they kind of touch base on what is the best approach for this individual patient. It's very easy to say like, oh, anybody that tests positive for stage 2 endometrial cancer needs this amount of chemo and this amount of radiation and call it a day. But that's not so easy to do when patients have other things going on. Their age will impact how you approach the treatment. Any other limitations? If they have if they undergo dialysis, they have kidney failure, things like that will affect what kind of chemotherapy this patient can receive, which will then affect what kind of radiation this patient can receive, and also can determine whether the patient's a candidate for surgery and just get surgery or not. So there's a lot of alternatives, a lot of options. So in tumor boards, doctors sit in, radiation oncologists included, and they discuss the patient. So here you have radiation oncology, surgery, and medical oncology. Medical oncology is in charge of chemotherapy. Surgery is, of course, in charge of surgery, and radiation oncology in charge of radiation. And we want to look at the patient and see what would be the best approach for this particular patient's condition, where the disease is located, where the cancer is. Is it possible to have surgery? Is it possible to, do everything through chemotherapy? And they discuss. So multidisciplinary approach. And of course, it depends on cancer type. So every doctor has a specialty, or every treatment site has a different approach. So if your doctor specializes on that approach, they will go to that tumor boards, breast tumor boards, head and neck tumor boards, and so on. Surgery. So surgery plays a very big role in radiation, in treatment. So it has a role in diagnosis. So it has a role in staging. It has a role as a primary treatment. Palliative treatment, which is treatment that just addresses symptoms, but it doesn't cure it. And identification of treatment response. So, for example, in diagnosis, we're talking about biopsies. There's a lump. Is it cancerous? There are different types of biopsies that can be done by the surgeon. So there's a fine needle aspiration. Fine needle aspiration. I'm going to address your book here. Fine needle aspiration is used to determine the histology. So the types of cells that are found within a lump. It's literally a needle. It goes directly into the lump, the tumor, and you just aspirate. You take some cells out, you put it under the microscope, and you look. Core needle aspiration, it's a larger gauge type of needle. So your book uses as examples 14 or 16 gauge, and it takes out a larger chunk, basically, of the tumor. So fine needle aspiration, you kind of put it into the tumor and angle it in different directions and try to get different types of cells from all around the tumor. Core needle, it's one big needle, and it takes out a core of that tissue, or like a big chunk of the core, the centerpiece of the tissue. When we're talking about endoscopic biopsy, it's when the surgeon goes in endoscopically, so there's some kind of camera going on. It could go like down the esophagus, and as they go in, they also have these kind of this tool that they're like pincers, and they'll pinch part of the tissue that looks suspicious. They'll see it through the camera and they'll say, that's what I want. And they'll pinch it and they'll take it out and obviously analyze it in a lab. Image guided means that there's some kind of imaging involved. So there could be ultrasound. You could use ultrasound to locate the tumor and know how deep the needle needs to go for like a fine needle aspiration. Or nowadays people are using MRIs to help delineate where that tumor is, and then you go in with your needle as you're able to also visualize it through the MRI in order to make sure you're getting a good size of the tumor sample. Incisional biopsies is referring to surgical approach where you remove part of the tumor and you go analyze it in a lab. And excisional is when you take out the entire tumor and all its surroundings. You basically give it clear margins, which means no residual disease. When you take it out, when you take that clump out, the center of it has all of the disease, and all around that tumor that you took out, you have clear margins. There's no disease all around it. Then your book talks about neoadjuvant versus adjuvant treatment. So neoadjuvant treatment means it's an approach that's done before the main treatment. So you determine what the main treatment. Your patient is going to have, let's say, radiation therapy is going to be the main treatment. But before we do radiation therapy, we want to do a surgery. So that would be called neoadjuvant surgery. It's done before the treatment, the main treatment. What is considered the primary treatment choice. So it is if it happens before, it's called neoadjuvant. If it's something that happens after the primary treatment, it's called adjuvant. After adjuvant. You can use that to kind of familiarize yourself. A lot of patients can have radiation therapy as a primary treatment to shrink the tumor, and then they will have adjuvant surgery to remove what's left. So neoadjuvant before the primary treatment, adjuvant after the primary treatment. Surgery is a local treatment. It's obviously you can only excise or remove local tissue. You can't go into the body and remove all the little cancerous cells in the blood. It's not possible. And of course, it is limited by the location of the tumor. Some tumors are not resectable. You can't go in there. So what alternative do you have if you're not able to reach these tumors? Radiation therapy! Yay! So radiation therapy is also a local treatment. It does not target cells that are free-floating or that have metastasized that might be in the bloodstream or could be floating throughout your entire body. It's really meant to be treating specific gross lesions or locally defined. It's less limited by tumor location than surgery, so you can reach areas with radiation that surgery can't do. You can treat millimeters of brain metastases. They could be 1 millimeters big. I'm talking 1 to 2 millimeters big, and you can treat those with gamma knife radiation. You could not just go in and treat and remove, 27 chunks of the brain and expect the patient to be functional, but you can actually treat 27 brain metastases with gamma knife radiation. Also, radiation therapy provides better cosmetic results. A lot of patients before used to get radical mastectomies. They used to get the entire breast and the muscle removed, and they would be, slightly deformed. And nowadays, patients can just get a lumpectomy and radiation therapy, and they have a much prettier cosmetic result. They feel much better about themselves, and they're able to have better mobility. And radiation therapy has a major role in palliation. So a lot of our patients, their disease has progressed to a level that we cannot cure them anymore, but we can relieve them of some of their symptoms, typically pain. So you will see a lot of patients that although their intent is not to cure, we do provide a lot of relief. We do provide relief of pain that allows them to live a better quality of life. So radiation therapy, there are two main modalities that we're going to talk about, and I'm going to start off with external beam. External beam is the one we see here. It's the one with the machine with the buttons. It's so fun, and the machine moves around the patient, and it's what you will envision when you think of radiation therapy. External beam consists of X-rays, electrons, protons, and gamma rays. So the high energy X-rays treat deeper tumors. Electrons are less energies obviously, and they treat superficial tumors. So the higher the energy, the deeper it can travel in the body and deliver a higher dose to deeper within the body. Electrons treat very superficially. Brachytherapy. Brachytherapy means short distance therapy. That's what that brachy part is referring to, short distance. So brachytherapy is done with radioactive materials, and the ones that your book discusses are cesium-137, iridium-192, palladium-103, cesium-131, and iodine-125. So these are all radioactive. These are all examples of radioactive material that we use in the radiation oncology department to treat different types of cancer. The sources are placed directly into or next to the tumor. So this is great for local treatment. If this disease has not metastasized, this is an excellent option. You just find the tumor and you find an apparatus that will help you place the seed directly into the tumor or right next to the tumor. And then what happens is the seed will come out of one of these. These are called afterloaders. These are the ones that house the radioactive seed. The seed will come out of the afterloader, travel through some channels directly where your apparatus is located, and just by the presence of the seed, it'll emit radiation and it'll treat at the same time. And it's not based on creating radiation. You're not creating it. It's already there within the radioactive source that is being housed inside of one of these afterloaders. Techniques for brachytherapy, we have interstitial, which means inside the tissue. So you directly use that. You directly place the radiation inside the actual tumor, inside the actual tissue. Intracavitary is when you are inserting the apparatus through a cavity, a body cavity, and then the radioactive seed travels through the apparatus. That's what you see a lot of with GYN cases when we're talking about endometrial or uterine cancer. You see intracavitary brachytherapy, and you can also have oral brachytherapy. It can be administered via radiopharmaceuticals, and it can be taken by mouth, of course, orally, or it can also be injected through the veins. Brachytherapy is great because it delivers a really high dose to a small area, which is a win because you're sparing a lot of normal tissue. If you're able to get the radiation directly into the tumor, so think about the prostate. The prostate is in the middle of your abdomen, or sorry, in the middle of your pelvis. If you're able to deliver high dose of radiation and treat the entire prostate with just an emplacement of radioactive seeds inside of it, you are avoiding first of all, you're avoiding weeks of treatment. You are avoiding irradiating other areas of the pelvis that are going to cause probably constipation or diarrhea. You're also avoiding having to bring the patient in so many times. Like sometimes it's 40 treatments, and brachytherapy can be done in 3, sometimes 5 treatments. So there are a lot of advantages to brachytherapy, and it is becoming more and more common. I would say for early stage disease, brachytherapy is becoming a very awesome option for that. And then of course we have chemotherapy. So chemotherapy, it's a systemic treatment. By systemic, it actually treats the entire body. So it affects not only the cells of the tumor, but also cells of the rest of the body, or healthy tissue, if you want to call it that, or cells that are circulating through the body. Because it is a systemic treatment, the side effects of chemotherapy tend to affect the entire body. So cytotoxic drugs that target, for example, cells like that are similar to the cycle of the hair follicles, they cause the hair to fall out, and the hair doesn't just fall out where we're treating it or where the tumor is, it falls out in your entire body. Radiation therapy, on the other hand, it's very localized treatment. Same with surgery. Localized treatment. Chemotherapy, complete opposite, systemic. And it consists of cytotoxic drugs. So they are drugs that target cells, essentially, and they kill the cells of the primary tumor and those circulating throughout the body. There are many agents that affect the cell during specific phases of the cell cycle. So that's why there's not just one chemotherapeutic drug for everybody. No, there are different chemotherapeutic agents that target the cells at different points in their cell cycle. And depending what type of tumor it is or what type of cancer it is, some drugs are going to be better than others. And the way that these are injected into the body is also going to differ. So, oh, I didn't talk about this. Oh, here we go. The chemotherapeutic agents. So they can be administered orally. Some patients can take pills that will deliver the therapeutic agent throughout the body. Some patients can have it through intra-arterial, and intra-arterial is actually when they're the infusion pump is connected to the catheter that has been placed in an artery that is near the tumor. Intrathecal is when it's injected into the cerebral spinal fluid. And then intravenous, IV, chemotherapy is the one that we see in this picture. It's the one that we usually imagine in our heads when we think about chemotherapy. Patients have either a port placed or their veins accessed, and they are connected to the pumps, which in this case is right here. The pumps, which those have the lines for the two different, or X amount of different drugs, cytotoxic drugs that will be circulating throughout the patient's entire body. Chemotherapy typically takes a few hours. Some patients have 30-minute chemo, and some patients have 6-hour chemo. And as a radiation therapist, you have to be familiar with their chemo regimen. You have to make sure that sometimes their chemo has to be tied to a certain amount of time before or after radiation. And you have to also keep in mind that if a patient is having chemo at the same time as radiation, they're probably not going to be feeling as great as those patients that don't get chemo at all. So we have different chemotherapeutic agents. Sorry. There are the ones that your book mentioned, so let's go over them. We have the alkylating agents. These are not cell cycle specific, but they actually work throughout the cycle. And the examples that they give for these are, let's see, cyclophosphamide and chlorambucil. I'm not great with these names, so I'm going to pronounce them really slowly. Antimetabolites act by interfering with the synthesis of nucleic acid. So these are cell cycle specific and are much more toxic to proliferating cells, so cells that are dividing, but are not associated with delayed bone marrow suppression or carcinogenesis. All right. And unlike the alkylating agents, which are associated to bone marrow depression and carcinogenesis. Examples of antimetabolites include gemcitabine and 5-fluoro, I'm going to call it 5-FU, which is what we call it in the clinic, fluorouracil. Sorry about that. It's the 5-FU regimen. You see it a lot in GI patients. Anti-tumor antibiotics are, they act on DNA to disrupt DNA and RNA transcription. So while these are not cell cycle specific, the effects of antibiotics are more pronounced during the S and the G2 phase. And examples of this are doxorubicin, which is adriamycin, bleomycin, epirubicin, they all end in sin, C-Y-N or C-I-N, because they are antibiotics. Hormonal agents eliminate or displace natural hormones. So the most common one here that I see that we see all the time with prostate cancer patients is Lupron. It's a very common hormone injected for the patient into the patient, and you see it a lot during radiation therapy. They'll come in kind of sore from their Lupron shots, and it helps suppress, let's see, a certain type of hormone that results in a better result for prostate cancer. Vinca alkaloids are the ones that stop cell replication in metaphase. So these are cell cycle specific. Examples include vincristine, vinblastine, and etoposide. Miscellaneous agents include the cisplatin and carboplatin, so the platinum compounds. These are seen a lot in like ovarian cancer. And then there's also the taxanes such as paclitaxel and docetaxel. So these guys are a little different. So they are disrupting cellular processes and also mitosis. So they are cell cycle specific. So a lot of names, a lot of difficult words. It's even hard for me to pronounce them. But the more you read into each different type of cancer, the more familiar you're going to become with these different chemotherapeutic agents and their names and their functions. There are the two words that your book covers, which is radiosensitizers and radioprotectors. So radiosensitizers are chemo drugs that help enhance the lethal effects of radiation. So when a patient goes in for chemotherapy and they receive a radiosensitizing drug and then they come in for radiation, your radiation is going to be so much more effective because they have been receiving this chemotherapy agent. There are other things called radioprotectors, which are certain chemicals that diminish the response of cells to radiation. So if there are radioprotectors around the normal cells, it allows the normal cells to kind of do or feel better when they receive radiation, or they just don't get as, or they're able to come back much stronger, much better than obviously cancer affected drugs. I mean, cancer affected tissue. Cancer cells have a much harder time recuperating from radiation, whereas normal tissue proliferates and recovers a lot better. But with radioprotectors, you're giving that normal tissue the chance to really avoid serious damage from radiation. And the cancer cells are, continue to be taken out by the radiation. And then the targeted cancer therapy. So these interfere with specific target molecules in the cancer cell that are responsible for abnormal growth and spread. So the targeted cancer therapies aren't necessarily interfering with the cell cycle itself, but it's with molecules that are responsible for abnormal growth and spread. Prognosis. So prognosis is the estimation of life expectancy. So it plays a major role in the treatment plan. And the way I want you to think about it is, if a patient has a long prognosis, so if you are treating, let's say, early stage larynx, which doesn't tend to have, it doesn't tend to metastasize very fast, chances are your patient is going to live a very long life, and your patient's in their 40s. Chances are your patient's going to live a very long life. So the type of treatment that you want to give them, you want to be aggressive because you want to make sure it doesn't come back. They are young, so they're able to tolerate it. And they have a great outlook. It looks like they're going to be just fine. Whereas if you have stage 4, metastatic breast, and there's a lot of metastatic lesions to the brain already or throughout the body, bone metastases, life expectancy is looking like it might be less than a year, you're not going to put that patient through an aggressive course of 6 weeks or something that they can't tolerate because the table's too hard or because they can't lie flat. You have to think, man, this patient has less than a year left or months left to live. Let's do something that's going to help them live these months to the best of their ability. Kind of like when you think about palliative treatments, or when you're thinking about what is the quality of life going to look like for these patients for the amount of time that is expected for them to live. So your treatment plan is going to differ heavily on your patient's age, their gender, their race, their medical conditions. Like they could be, 35, really young, and have great outlooks, but they might have other medical conditions. They could have failing kidneys. They could have it could be anything. So you have to take all those factors into consideration when you're thinking about the treatment plan. Tumor-related prognostic factors, you're looking at the grade, the stage, the tumor size. So smaller tumors, better prognosis. Larger tumors, worse prognosis. Um, the stage, how spread is it? Has it affected a lot of lymph nodes? Has it, is it still just in situ? The histology, does this type of cancer tend to be more aggressive or tend to metastasize more than other types of cancers? And then when we're talking about patterns of spread, we're talking about what is the likelihood of this cancer to spread or this type of cancer to spread. So, fun fact is more localized tumors tend to have better prognosis than those that diffuse early. So, of course, if the tumor tends to just grow really large but not spread, that's actually better than if it's a small type of cancer or a cancer that's already very close to the bloodstream and it might not be this obvious lump, but if it spreads easily, it's going to be much more dangerous. Um, and then the exophytic tumors are tumors that are very, very large. They tend to grow outward, but they don't spread. So as ugly as they might look or they might feel, they don't spread through the bloodstream as easily. So they actually tend to have a better prognosis associated to them. And tumor dissemination can be accomplished through the blood. So tumors can disseminate or basically spread via blood, lymphatics, and seeding, which seeding is when the tumor itself starts to break off and affect nearby structures. The common metastatic sites of primary tumors. So if you look at the lung, it tends to metastasize to the liver, the adrenal glands, the bone, and the brain. Your breast cancer tends to metastasize to the lungs, bone, and brain. The stomach cancer tends to metastasize to the liver. Anal cancer goes to the liver and lungs. Bladder goes to lungs, bone, and liver. Prostate goes to bone, liver, and lungs. And uterine tends to go to lungs, bone, and liver. So you see a lot of common factors here. If you have cancer in the liver, or you have cancer in the bone, or you have cancer in the brain, it's a very high likelihood that it's a metastasis from something else. Of course, it could be a primary, but likelihood is that it's a metastasis. Finally, clinical trials. So clinical trials are a collaborative effort among the different disciplines to try to find the best and most effective treatment choice. So it's research at the end of the day. The different clinics, your medical oncologist, the surgeon, the radiation therapist, immunotherapy, they all come together. They all say, hey, let's try this new drug, or let's try this new regimen, or let's try this new protocol and see if it works better than the standard of care. There are different studies that clinical trials use. So sometimes you have retrospective studies, and this is when you look at data from the past and you analyze it to see if something from the past already works. So it's not an experiment that you're currently carrying on. It's an experiment that it's looking at past data to determine if something worked or something developed, or if the approach that was used in the past resulted or ended up having better results than it does, better results, and if it can be applied into future treatment options. So retrospective studies, the good thing is that the information is already there. You're just digging into it and trying to find patterns. You're not waiting a long time for results. But of course, because it's basically looking through studies that are from the past or things that have already happened, you can't control for a lot of things. There may have been factors that you wish you could change or control. You can't do that. You just have to take the information that is already there for you. Now, prospective studies, these are the ones that are planned before treatment. There's eligibility criteria. So you're selecting who you want this treatment to go to. Sorry. You're selecting your eligibility criteria, you're selecting your treatment drug, you're selecting everything from scratch. It's happening live, if you want to think of it that way. There are different types of phases. So phase 1 studies, they are trying to figure out the maximum tolerance for a specific treatment. Phase 2, they're trying to determine whether the phase 1 is significantly effective to continue further study. My apologies. Phase 3, you're comparing the experimental treatment with the standard treatment with random people. So you're taking in people and you're saying, let's try the standard of care on you and let's try this experiment on you and see which one does better. And stage 4 are the ones that have already been approved by the USDA. All right, and randomized studies. So we randomize studies because we want to increase the accuracy of results. We don't want biased results. We randomize if we don't know what patient received what drug, and we're really able to follow them equally, the ones that are in the standard of care pool and the ones that are in the experimental pool. Then we're making sure that the results that we receive are accurate and that the conclusions that we're drawing are also reliable. And finally, the radiation oncology team. This is us. So at the heart of it all, the one with the most responsibility is the radiation oncologist. This is the doctor. The radiation oncologist is your doctor. They are the ones that prescribe. They are the ones that determine what the treatment is going to be for the patient, what the dose is that they're going to receive, what the fractionation schedule is going to be. They are the ones that talk to the medical oncologist or the surgeon and determine, is radiation going to be neoadjuvant? Is it going to be adjuvant? Is it be in concurrent with chemo? Is it going to be for palliative purposes? All of those conversations and those determinations are done by the radiation oncologist. In the radiation oncology team, so right when you walk in to the department, you're going to see the clerical staff members. The clerical staff, they are the first people that the patient sees. They're the ones with the smile on their face to say, hey, welcome again. Again, our patients come in many times. They don't just come in for one appointment and we never see them again. That's not very common. We see them a lot. We get to know them really well. So the clerical staff members, a very important part of the team. They're the ones that tell us when the patient is here. They're the ones that communicate to us as well, kind of what the situation is with the patient, with the family. Are they coming in by themselves? Is the family dropping them off? Does it seem like, this patient isn't doing very well today, can't stand on their own? Clerical staff is the first person to see that patient when they walk in. They're the first ones to inform us of anything that they, suspect could be affecting the patient. Support staff members, that's when we're talking about nurse navigators, or sometimes we're talking about social worker. They are there to provide support services for the patient. So if the patient has transportation issues and they need to get transportation set up, if the patient has other appointments that go hand in hand with chemo or hand in hand with immunotherapy, the navigators or the social workers are the ones that are there to help support the patient, because there's a lot of appointments going on at the same time and the patient just can't keep track of all this. So we're here to do all of that for them. We just will ask them to show up and we'll take care of the rest. At least that's what we try to do. The nurses, you work alongside the nurses all the time. The nurses are there to assist the doctor in consultations. The nurses are there to place IVs. The nurses are there to administer medication if needed for inpatients. The radiation therapists, that's us. We're the ones that deliver the treatment. We are the ones that see the patients every day. Out of everybody here, the only ones that see the patients every day are the clerical staff members and the radiation therapists. But the only ones that actually bring the patient into private spaces, which is like where we do our treatment, is the radiation therapists. Clerical staff see patients in the front. I like to think of it as like they're not as vulnerable or they're not as open. And then once we bring them back to the treatment room, they're obviously a lot more vulnerable. A lot of them don't have any clothing on. And that's kind of when we really get to see what's really going on. The dosimetrists. So these are the dosimetrists are in charge of the treatment plan. So a lot of dosimetrists nowadays, they do remote work because their job is really, once the simulation is done, so once the therapist is done with the first appointment with that patient, we send the CT images to the dosimetrist and they are in charge of creating the treatment plan. So telling the machine how much dose is going to go where. And it's computer work essentially. So they sit in front of the computer a lot. They talk directly to the radiation oncologist to make sure that they are achieving the goals of the radiation oncologist. And then the radiation physicist are in charge of looking at that plan and approving it and saying, yes, this treatment that this dosimetrist created, or this plan, is safe. They are the ones that deem the treatment safe for the patient. The radiation oncologist says, I want this structure to receive this amount of dose, the physicist makes sure that the plan that was created is safe to be delivered for the patient. It is not going to harm um, any extra structures in a very negative way. And they also are in charge of machine. They're making sure that the machine is delivering radiation correctly, daily output, calibration, calculations, all of that is done by the radiation physicist. Now, how do the responsibilities change when the team is part of a large department? So when you work in a hospital setting, which is where I work currently, the team is very large, consists of a lot of people. Um, and what happens is everybody is very specialized. So the more people in the department, or the more physicists and doctors and nurses and treatment machines even, the more machines you have, the more specialized they are. Usually you have one machine that does certain types of treatments, other machines that do other types of treatments. You have one doctor that focuses on or specializes on head and neck, one doctor that specializes on breast. Um, and therapists, your job duties really become to treat the patient. Your job is to go get the patient, treat the patient, make sure that the treatment was delivered safe and effectively and accurate, and then you walk them back out. But what happens when you're in a small clinic? When you're in a small clinic, you might have just one doctor, you might have just one machine, you might have just one nurse, and your support staff members might not be there every day. They might come like once a week. So you, as a therapist, your responsibilities kind of grow a little bit more. You do become partners, and you do become part dosimetrist and part physicist, and the reason for that is because you don't have as many members in the team, and you have to kind of step in a little bit more. Is that necessarily bad? No. It makes you a much more well-rounded therapist, and it also helps you travel or live the patient experience more completely. When you are just treating all day, you don't know what the interactions are with the nurses, you don't know what the interactions are with the doctor, you don't even know if the patient got to see their own doctor. Sometimes they get to see another doctor, and the patient could come in 10 times, and 4 times they wanted to see a doctor and they saw 4 different doctors because it's such a large department. So there's a little bit of a disconnect with the patient treatment when it's a larger setting. When it's a small clinic, everybody knows everybody. The doctor feels comfortable to come in and talk to the patient. There's more free time, for the doctor, or less real estate for the doctor to get lost or pulled in different directions. Like it happens in a larger setting. So pros and cons to each, but I think it's very important, and I'm sure you will experience it when you go on your clinical rotations, that you get a little bit of both, so that you get to see, the pros and cons of each yourself, and you get to live it, and then you get to choose when you graduate what kind of setting you prefer to work in. But yes, that's it for week 1. That's it for week 2, chapter 1. I will see you guys again next week for the week 3 lecture. Thank you very much.